comes rum coming everywhere. So prepare, say a prayer, send the word to beware. We'll be over, we're coming over, and we won't come back till it's over, over there, over there, over there. Send the word over.
Hey everybody, this is Joshua Littrell. Thank you so much for joining us here on the Veterans for Cannabis podcast today. I'm really excited to bring you a lot of great information. This is going to be a two-part podcast today, so please tune in to the second part of this. We have a really, really great guest today and going to bring a lot of great information to the veteran community, but this also touches out to everybody that may be suffering from post-traumatic stress. Dr. MARION MCNABB, how are you doing today, ma'am?
I'm doing great, Josh. Thanks for having me on today.
Absolutely. Dr. MCNABB, you are the president of the Cannabis Center of Excellence Incorporated.
Yes, I am. Yes, so the Cannabis Center of Excellence is a 501c3 nonprofit organization, and our goal is to advance the cannabis industry in the areas of research, citizen engagement, advocacy, education, and social justice.
Wow, I tell you, you and I have known each other for a couple of years now, and you've got some really great information in some of the things that you've worked on in the past. And I think that's really what we're going to focus on today is bringing some of that data and information out to the forefront. So when we look at the industry as itself, the cannabis industry, where's all the data at? Does it exist?
That's a really good question. So it depends on, I guess, what type of data we're talking about. So in the areas of industry data, understanding, what consumers are purchasing or, where the market's going in terms of, are people purchasing more extracts or more flower? There's those type of point of sale data groups that are out there. That would be like a BDS Analytics or Frontier Data, and those groups are really important to understand industry trends, and sort of business intelligence. When we talk about clinical research data, that's a very different story in the United States. As you know, researchers really have to apply through NIDA to have access to cannabis that's cultivated at the University of Mississippi for their approved clinical trials. The process to apply, get approved, conduct, and publish the results for those kinds of research studies can take and have shown to take up to a decade.
But Dr. MCNABB, there's no way. I mean, because, just a couple of years ago, they said the DEA was opening it up and they were going to allow people to study, right?
Right. And they haven't made a lot of movement on that.
Right.
They did open up and say, took some applications of some other, cultivators that could be part of the program, but it hasn't moved forward, very quickly. So researchers are still left with the University of Mississippi, unless you're in a state that has supported cannabis research or has tried to do it at a local level. So either funding cannabis researchers through tax revenues, such as in California and Colorado, or other states like Massachusetts, which are now setting up a research license for cannabis researchers to be able to cultivate and study on site.
And I think that's really, what the key is doing it by the state, because as you well know, and I do, and I think most of our listeners do, they're all really familiar with Dr. Sisley and the issues that she's had through the years. So it's not just her, it's you, it's all the research, data, the analytics, the things that patients need that can force the state and federal governments to make the changes we don't have access to do the research with, right? But if the states are going to administer that gives us a great new opportunity now. And we'll get into that. I want to really, we're going to get a lot of great information on the study that you guys conducted and just some benefits that came out of that veteran study. But before we do that, tell us a little bit about your background, Dr. MCNABB. Where are you from and kind of how did you get into this?
Yeah, so I actually grew up in Georgia and traveled around and lived, went to different states for my undergraduate, which I studied African and African American studies. And then I proceeded in my previous to cannabis career. I was working in global public health. So after I graduated college, I actually moved to Ethiopia and spent about 8 years there, working with U.S. government funding, USAID and CDC and DoD funding to support the Ethiopian Ministry of Health to set up and establish HIV/AIDS programs, prevention, care, and treatment programs. So I also worked, it was a really wild experience, and something that I think definitely shaped me, my person, my career, and my worldview. And after living for 8 years in Ethiopia, I decided to, I got my master's in public health while I was living abroad, actually from Johns Hopkins University online. So if you can imagine doing a master's degree online 10 years ago in a country with only dial-up,
wow.
It was a little bit challenging. I was on the forefront of online education. So I finished my master's while I was living abroad, and then about 10 years ago decided to move back to the United States to pursue my doctorate in public health. So I joined Boston University School of Public Health and spent 7 years working still on international global public health, and I broadened outside of Ethiopia and worked probably in 10 countries on 12 projects on various health topics from, like I said, HIV/AIDS, family planning, maternal child health. So towards the latter part of my global public health career, I specialized in digital health and digital technologies. So how could we leverage mobile phones, apps, SMS texting, WhatsApp, et cetera, to reach the poorest of the poor with either health information or creating like mini electronic health records for community health workers.
How did that work out? I mean, how do you get to those people? Because when you have very little technology in a third world country, how do you get that information out to them? What was that process like? That's really interesting to me, just personally.
Yeah. So in some cases, there's widespread availability of very simple mobile phones, so not smartphones. So you can do a lot of work on texting and text message campaigns and reach a lot of people that way. And as we've seen, I think now mobile phone ownership is skyrocketed. So I've been doing that work. But for the clinical decision support tools, or like the mini health records, it was quite interesting because I was working in Haiti for about 3 years, designing a system that would support 30,000 community health workers that typically were older or retired, nurses. And so they really were not familiar with mobile technology and oftentimes didn't have a phone. So we created partnerships to actually provide those devices and then conduct training on how to use them, and try to develop incentives for, really encouraging their use. I think when you look at healthcare abroad, a lot of record keeping is paper-based. So these community health workers will be walking around with 4 to 5 logbooks, and filling in paper information. And then it takes them a really long time to aggregate that data and then, be able to prepare a report. So the mobile tool for them saved them a significant amount of time in data entry and improved accuracy of data collection, and then was able to really offer these community health workers interactive videos or educational videos or other job aids that they didn't normally have when counseling clients. So it was really, very powerful to see some people really, would jump on the technology and learn, and then others, just wasn't really interesting to them.
Oh yeah, you still got that old school mentality.
Yep, like I like to write it on my paper, and I don't want to be forced to do this. So yeah, I know that digital health interventions have really transformed the way that global health can operate, and especially now in COVID. But other projects I used to work on were like returning of lab results. You go to get an HIV test, and then it would take a couple of days to get your result, and you'd have to walk back or travel back to the health facility. And then you lose a lot of people from actually getting their test results that way. So, by delivering a secure message to them, you're really improving patient retention and engagement. There's a lot of exciting ways you can use technologies.
With everything we've got going on with COVID right now, with COVID-19 and the pandemic, you as a public health just aficionado, for lack of better words, when will our entire country move to a completely digital, in your opinion, completely digital record system? And do you really think that virtual doctors are here to stay?
Yeah, I do. I think telemedicine is a very effective tool, especially in COVID. I've been working in telemedicine in Ethiopia I was doing telemedicine there now almost 20 years ago, it feels like. And I think it's a really effective way to be able to reach those who can't travel to a health facility and, provide some preventive or behavioral health services or things that don't require lab tests or physical checkups. Really improves, patient attendance and, also doctors being able to follow up. I myself had a telemedicine appointment last week. So I'm actually really glad to see that, moving in that direction. Of course, phones and digital and technologies will never replace a human and will never replace human interaction. So, I always used to say a phone can't deliver the baby.
That's right.
But, engaging in these kinds of telemedicine or teleradiology or that kind of consultation, I think is really important for moving to a digital record system in the United States. I've focused a lot of my work internationally on designing national information systems and moving towards that direction where you would have one electronic medical record, one reporting system, and, be able to streamline how countries report their health statistics against other countries. I think one of the challenges of the United States is that there's more electronic medical records out there than you can even imagine. They're not interoperable. There's some data standards, that are reportable, like identifiable diseases, et cetera. But the data exchange between healthcare systems, primarily because they're privatized, that all is really lacking and creates an inability to really have a larger understanding at a national level of a variety of health conditions. There are some interesting movements in the United States moving towards trying to better understand, national health information systems and, but I think because the healthcare industry is really privatized, that limits, unless there's one. I know that under the Obama administration, there was a lot of work towards thinking about digital health and national systems. I don't know if the current administration is as focused on that, though.
Well, I think one of the things that, and I'm a weird situation in this whole point of view, if you will, because I see on one side the need for a huge database to collect information and data so that we can see trends, we can stomp those trends out and take care of issues as they arise, right? But then on the other hand of it, I hate the big brother. I don't want them looking at my medical records. I don't want one centralized location for somebody to hack into and get my information. So where in the world do we create that happy medium to where people feel good about the security that they've got and they don't have to feel like somebody's breathing down their neck or looking into their lives, right? And then two, we have an ability to reach in and get the information in a central standardized format and place where we can really determine what's working well for patients and what's not working well for patients, So it's such a quagmire for me, just personally.
Yeah, and I agree with you. Nobody likes the big brother approach. So I think, it's important, and this is why I actually focused on anonymous research studies in the past couple of years related to cannabis, because, especially with cannabis being, federally illegal, people are more hesitant. But I think, there's two ways that could be done. There's, your own private healthcare, which it should be HIPAA compliant, your own ability to opt to share that information. In my personal opinion, it should be to share anonymously, but with, key demographics associated. So maybe like age, gender, ethnicity, those kinds of things, but not necessarily your private health information, your name, your social security number, your address, that kind of stuff. One of the exciting studies that I've been looking at for a